Hello again. Welcome to part 3 of this presentation. In this part, we will discuss rest of the uh, content on pain mechanisms in osteoarthritis from where we left in the last part. Now, in that, I'll talk about exercise and electrophysical agents, given the interest of time, because those two are they are not resource intensive, not resource intensive. They are feasible to apply, and they are very commonly used, right? Which is why I have chosen these two interventions in the interest of time. Now, if you see the exercise, there are a variety of exercise that we can prescribe for patients with knee osteoarthritis, say aerobic exercise, neuromuscular exercise, strength training, balance training, and the list goes on, right? So the current research says there is evidence from almost more than 50 randomized control trials that exercise have beneficial effects in lower limb osteoarthritis. So exercise improves pain and function. But one of the challenges is that the effect size seem to be moderate. Effect size is a quantitative measure of how much the intervention is effective on a scale graded on a scale of 0 to 1. So if it is towards 1, the effect sizes are large. It has more effect. If it is towards 0, like less than 0.3, you call it as a small effect size. But overall, the current evidence indicates exercise has a moderate effectiveness. That is what I was saying earlier. So in an ideal scenario, we want this effectiveness even to be higher. You want it to be even higher, provide more pain relief and resulting in more functional benefits. But the general consensus is exercise is the first line of treatment and it is effective. Now, moving to the effect of exercise on joint pathology, I want to take this review, a recent review, which has looked at a lot of animal and human models that has looked at the effect of exercise on peripheral markers of joint pathology in knee osteoarthritis. So this again, I just want to highlight the conclusion here. You're more than welcome to read the full article. I just put the conclusion. So this review has said that weight-bearing exercises such as walking can induce cartilage degeneration in knee osteoarthritis patients, right? However, it is important to note that this increase was not significant compared to healthy controls. Next, these changes are only transient. So there is a possibility that weight-bearing exercises can induce cartilage damage, but it is not a certainty. There is a possibility. Later, again, I give this is a full disclosure that this is based on the review's findings. Next, non-weight bearing exercise such as straight leg raise, they show an effect where there is a significant reduction in cartilage inflammation. They are saying that non-weight bearing exercises may be more beneficial, which is in line with the expectations as well. That weight-bearing exercises could result in more damage, whereas non-weight-bearing exercises are safer, right? So if you answer the question, can exercise affect peripheral damage? Yes, it has both. It has positive effects and probably questionable negative effects, I would say at this point. This is only a narrative review. You need a systematic review on this, but I couldn't find a systematic review, so it's questionable whether exercise results in any damage or not. Next, the effect of exercise on central sensitization, the next pain mechanism. Here, again, I found a systematic review, which is again a collection of studies. Systematic review is considered as the highest level of evidence. I should have told this earlier, so this systematic review has concluded based on around 12 studies, 12 to 15 studies, that there is low quality evidence showing that exercise may not have an effect on pressure pain threshold and temporal summation. And it is also pointed that the quality of evidence is low in this area. Like, can exercise affect central pain? Now, like we know a lot of biomechanical benefits of exercise. Exercise improves muscle strength. Exercise may improve joint stability. And there are systemic effects of exercise. Exercise improves the systemic inflammation and the other systemic aspects associated with osteoarthritis. Now, if you see exercise and central sensitization, currently the evidence is not in support. But since it is of low quality, the future evidence might change this conclusion. So if I have to summarize the effect of exercise on pain mechanisms, Probably it could affect peripheral pain mechanisms, but may not have a significant effect on central sensitization at this point. Next, moving to the electrophysical agents and peripheral joint pathology, I could find some preliminary evidence showing that ultrasound and laser therapy has benefits on modifying the structural environment of the joint. It improves the healing and etc. Pretty recent evidence. And the evidence for exercise therapy and the electrophysical agents or electrotherapy and central sensitization, I could only find 2 studies with very low sample size, but they show positive effects that saying high frequency and low frequency TENS increase the pressure pain threshold, and intramuscular electric stimulation enhances the corticospinal inhibitory system. So there is preliminary evidence that electrophysical agents could potentially modify both peripheral and central mechanisms. But if you see in the guidelines, electrophysical agents are not considered as core treatment. They are only considered as adjunct treatments because the evidence is not pretty good, and also it's not of high quality. That could be the reason why they didn't get a place in the core treatments. So that means I would say there's more work to be done, more evidence, more research to be done in this area, and see if the present conclusion changes in the future. Lastly, I want to put this point again, electroacupuncture. Again, I'm not saying this would fall under the typical curriculum of physio, but then which has similar type of mechanism as physio modalities. So I found this trial, which is a large randomized control trial because it included 300 participants, which is very, very big trial. And they looked at the effect of electroacupuncture on conditioning pain modulation or on descending pain modulatory systems, right? So if you see this graph, after 2 weeks of electroacupuncture, there is a significant increase in the conditioned pain modulation. Means there is strong stimulation of descending pain modulatory systems with electroacupuncture. Now, some of our modalities also have hypothesized same mechanism of action, and unfortunately we don't have such a strong trial in support of TENS or any other physiotherapy treatments, and yeah, that's a point to be noted. So this is my last slide with respect to evidence, and I would like to keep it to integrate what I have discussed so far into 4 possible scenarios. I try to keep it as simple as possible into 4 scenarios. So clinically, you may find patient with joint changes and no pain. So a patient may have cartilage degeneration and may not experience any pain. And you may have another scenario where there are joint changes, but there is no central sensitization, no psychological factors, but there is pain. Right? This could be another scenario. You can profile a different participant into this kind of a clinical picture. The next scenario, you may have the patient may have joint changes. They may have enhanced central sensitization and no psychological factors and the presence of pain. Lastly, you may have joint changes, enhanced central sensitization, psychological factors, and pain. So if you see, if you come from top to bottom, the last group, the profile is one of the most challenging ones to manage because there are joint changes, there is enhanced CS, there is psychological factors and everything. Now the question is, how do we integrate or how do we tailor our treatments addressing these different aspects and also integrating the evidence? Now, again, these are my initial thoughts. I just want them based on the research. I'm providing some recommendations. It is again at the discretion of the clinician. So now if you see joint changes and pain, since there is no pain, I would say you can prescribe both weight-bearing and non-weight bearing exercises since there is no pain. Usually the recommended dosage of exercise is that you do in older adults is that you do a combination of aerobic strength and balance training. You may be able to prescribe all the 3. And I don't think there is no need for any other treatments, right? Pretty straightforward there. Now the question next is the next group of patients. This group has joint changes. There is some structural pathology. There is no central sensitization and no psychological factors, but there is pain. So now if you want to address the joint changes, there is some preliminary evidence, but not of high quality, to use electrophysical agents to manage the joint changes, right? Since the joint changes are associated with pain, I would say probably non-weight bearing exercise are a better choice. Right? These are the two aspects I would like to management aspects that I would like to consider. No central sensitization and no psychological factors. Obviously, there is no need for those interventions. Right? The next group, the patient who has joint changes, who has enhanced central sensitization, no psychological factors, and pain. So if you look at the evidence, if I have to manage the joint changes, again, probably I would consider electrophysical agents, but there is enhanced central sensitization. I want to really inhibit their central sensitization, or I want to improve their descending pain modulation. Here, based on the evidence, I would say exercise don't seem to have an effect on central sensitization, but electrophysical agents don't seem to have a strong effect, but electroacupuncture seems to have a good effect to induce descending pain modulation. So probably I can use this in this group to improve central sensitization in these participants. Right? Again, these are all hypothetical. These need more research to be have some conclusive evidence. The last patient group is the most challenging. You have joint changes, enhanced CS, and psychological factors. Probably these are the group of patients you need a consultation with a psychiatrist or referral to a multidisciplinary pain management program or that sort. So these are the four possible scenarios, and I tried to simplify it. I hope you found it simplified. And lastly, I would like to end by saying two key points based on what I have said so far. The first point is that the pain is multifactorial, yes, and that's a key message that I want to say. If you take that, that's I'd be happy to know. And then the next point is that we need to shift our focus to mechanisms that are responsible for treatment effectiveness. We have reached so far in establishing treatment effectiveness. Probably the next step for us to is to look at the mechanisms based on which how treatments work, and if possible, tailor the treatments towards the pain mechanism. So with that, I'd like to stop, and I want to thank Dr. Sonal Kolke for introducing and being here at this hour, and also Dr. Suroshi for giving the opportunity, and the entire team at I guess Sancheti College of Physiotherapy for giving this opportunity. If you have any questions, here is my email. I'm very happy to chat. Thank you so much.
So thank you, Dr. Raghav. That's really been a very informative talk. And I'm sure to concise whatever you've done in pain and to put it across must have been a task. But I
Yeah.
think you have kind of tried very effectively to kind of explain to us the central pain mechanisms and how they operate and how they are significant in a patient of knee OA. I guess any patient who has chronic pain,
Yes.
all right. I always consider this, and I'm sure you agree with me, and you've had your clinical experience in India too. It's a very different category of patients that we handle, you know. So
Yes.
I guess we have seen this in back pain also, that even when two backs look very similar in their investigations and maybe even their clinical signs, tend to respond very differently to treatment. So what works for one doesn't work for the other. I think just like no two backs are the same, no two knees are the same. And I guess you try to do your best to categorize patients in four categories, but I think there are many more categories. And depending upon, of course, the level of the CSI or the psychological involvement or the structural and the other involvements, I think we deal with needs which each patient teaches us that what works for one doesn't work for the other. And I guess through the line, I think the world also is moving towards more active treatment techniques and active treatment modalities to kind of tackle the pain and the pathology which is associated with musculoskeletal disorders. So I guess I had even read some systematic reviews, and I had come across this very interesting another study in which there was a orthopedic surgeon who kind of induced, I mean,
Yeah.
he himself, if you have read that article, it's
Yes,
really,
yes.
really interesting to find out
Yes.
what are the pain generating structures. And a very interesting finding in that was the inferior fat pad, you know. So the fat pad, it was so, so sensitive at the infrapatellar region that, so that's one more pain generating which we usually tend to ignore because we do not think there's something there. Yeah, so I guess that's what. After treating so many needs and this thing, I do agree that we are moving towards a place where we are trying to understand the biopsychosocial involvement of, the entire thing which is playing on a patient, and, maybe amplifying his pain or maybe not coming in way with his pain, regardless. And we need to know these phenotypes, or we need to know all these demographics, or other characteristics of a
Yes.
patient which may kind of modulate or maybe have a strong effect on their pain behavior.
Yeah,
So,
I totally agree, man. I like the point where you said there are more categories. Yes, I totally agree. It's actually a challenge to only bring down to four
no,
because I
but
don't
you
want to
did your best.
complicate.
So
Yeah,
I
yeah,
agree with you that,
yeah,
it
yeah,
is a
yeah.
challenge, and yet you have tried. And I guess,
I like that point very much. And the levels of sensitization also, that is what we are seeing in our data as well. The, like, as you said correctly, the levels of sensitization is one, and also the levels of peripheral pain is one. And as I said, the pain is multifactorial. The
yes,
multi
it is.
represents everything, and it's very fascinating that the physio practice is also moving towards acknowledging the multifactorial and managing. I assume, like probably when I finished my bachelor's, it was not the scenario. I mean, it's just an assumption. But over the years, there has been so much change. So, like even when I talk to colleagues across my friends, and everyone seems to recognize that, and the central factors are not acknowledged everywhere equally, and we are leading, I would say, in that aspect. There, I mean, even I'm seeing clinical practice. It's most elsewhere. It's mostly peripheral dominant, but we are doing a very good job in considering both central and peripheral.
That's very good. I guess we look forward to some more publications coming from you from that end. And, but this talk has really helped us sensitize as well as improve our understanding about how CSI, or a central sensitization, has its role to play in amplifying pain in some way. And I think we need to consider what is your experience about CBT? I mean, because we had a lot of positive, evidence gathering or garnered around the world about CBT, but very lately I've even seen conflicting evidence. So, what is your take on it?
I talk from my clinical experience, and I'll wear two hats, clinical and research.
Yeah.
So I'm currently not a clinician for the past three
Okay. Yeah.
years.
Right.
So yeah, and so if I have to talk from the clinical experience, CBT, it depends on the way we deliver it. If you tell a participant, okay, we are delivering a CBT, they will be generally taken back with the stigma and everything. But I feel we do CBT very informally in all our interactions. So I mean, with the patients. So
Mm.
which the essential principles of CBT, we keep talking. The patient shares about their stresses and etc.
Exactly.
We do try to coach them. We don't document, or probably we don't do it in a structured way where you sit and talk to the patient. But say, for example, when the patient is doing exercises, we talk to them. I would say that as CBT. No. And we kept a modality and we are talking them. I would say that as CBT rather than a table and chair approach, which is done in a traditional way. We do it in our own way, and that is very effective, I would say. And the moment you introduce it as a psychological intervention, there is some stigma around it, and it actually increases their worry a little bit. That is my clinical take on it. And research wise, again, I think this is slowly getting reflected. Now, if you see, the highest amount of evidence for chronic pain is actually CBT. Like
I
across
know.
all
That's why I was telling
the
you.
yeah, across all the treatments that we have,
I
it has the highest amount of evidence in terms of research. Yeah.
Yeah. In fact, many physiotherapists are getting their training into
Pain.
CBT so that
Yeah.
they are able to deliver that part of the treatment also. So that's
Treatment.
also
Yes.
this thing. But I saw a little conflicting evidence. So I wanted to know whether you are having any, experience
Yeah.
in that
Yeah.
area
Yeah.
or not.
Yeah.
But yes, I guess we'll always have two sides of a coin and we have to go
Yes.
by
Yes.
whatever. And as you correctly pointed, many of the electrophysical agents that we are using. So I've seen that for the use of back pain also, and I've seen that for OA knee also. There's not been good quality research which has been
No.
carried out. And because of which, and very often we do not have research which looks into the long term. Post intervention, after the intervention is stopped, how much is the retention of that effect? Like how you said that there are certain modalities or even exercise wherein you can see that effect on the central sensitization or for the structural thing only for a limited amount of time. And the minute it's discontinued, you usually have things going back to what it was, and then the patient keeps coming back with the same complaints again and again. So I guess we need to know how we can taper down a program such that the retention effect is more than what we have gathered. And not many people tend to follow up patients or try to find out how far, the pain has really been effective, pain relief rather has been effective because of whatever we have tried on them. So I guess we need some studies which are more long term and following, as well as good quality RCTs which can kind of even bring out the essence of many things that we see works in the clinics, but presents as very low evidence when you look at, so many guidelines. I mean, even CPGs all over will kind of pull down many of the electrophysical agents and many of the passive therapies and will move to highest evidence towards maybe superficial modalities, heat and cold, and, patient education and other things. So we need to kind of garner more evidence and have good quality studies which can have a better effect. Anyway, so all in all, thank you so much from the entire team of Physiotech TV. I would really, really like to thank for such an informative talk. And I hope we can rope you in for more future talks because this has been just
Sure.
I'm sure, tip of the iceberg that you introduce us to. And each of the things that you mentioned can be dealt into more, yeah.
Yeah.
So thank you
More,
so
yeah.
much.